Which safety measure are appropriate? Select all that apply. What is furosemide, guys? Loop diuretic? Yeah. So loop diuretic. It works by inhibiting sodium potassium chloride co-transporter. Yeah. And it work on thick ascending limb. Okay. Do we need to worry about A? Is it a safety measure? Administer slowly over 1 to 2 minutes. What is the recommended rate for furosemide? What is the recommended rate, guys? Anyone, please keep double tapping. Share your rationale why you think it's A. Why you think it's A? And that's why it's good to know, mostly like, the students that we have who recently cleared the NCLEX, because they got the same questions. Yeah, 1 to 5 minute. Yes, 1 to 2 minute definitely. Yeah, and basic rate is 20 to 40 mg per minute. Okay, what will happen if we will administer it fast? If we will do rapid? Yes, you can, Nicole, you can. What will happen if we are rapidly administering furosemide? You need to be slow, but what will happen? What furosemide can autotoxicity? Yes, no, and me, definitely. It's gonna cause autotoxicity, guys. So please remember that. Okay. Okay, do we need to monitor potassium level? Yes, because loop diuretic known to excrete potassium. Okay, yeah. So the patient can have hyper or hypo. Yes, Kemi. Yeah, hypokalemia. Okay, because loop of Henle, when it work on loop of Henle and ascending loop, it excrete everything out. Okay, assess blood pressure before administration. Do we need to do that? Yes, definitely yes. Because what will happen if we are not assessing? It is a potent loop diuretic. It is potent loop diuretic. Patient's blood pressure gonna fall significantly. Okay, so we need to assess the C also. Expect hyperglycemia in some patient. Okay, it's not in every patient, guys. So this is the key word here. In some patient, can we expect hyperglycemia? Yes. Yeah. Can we expect hyperglycemia? Yes, guys, we can expect. To release the insulin, what we need to release the insulin? That is related to this medication. To work on beta cells, what we need? Anyone? Or shall I go? So to release insulin from beta cells, you need potassium. Okay. Nicole, the question is that why we expect hyperglycemia in some patient. You guys need potassium because potassium is also one of the factor that help to release insulin from beta cells. Okay. So that's why when this medication furosemide, this medication excrete too much potassium, cause hypokalemia. There is less potassium available in body that will help to release insulin. Okay, when we have less insulin body, what will happen? Less insulin body now, what will happen? Guys, come on, comment fast. Hyperglycemia, yes. So we can expect hyperglycemia in patient. Okay, not hypo. When there is less insulin in body, guys, when there is less insulin, we can expect hyper, not hypo. Okay, if there is too much insulin in body, then we will expect hypo. Okay, yes, hyperglycemia. So we can expect hyperglycemia in some patient. Okay, do we need to restrict fluid to prevent dehydration? Thank you guys for double tapping. No, we don't need to restrict fluid because the problem is that we are giving furosemide to reduce the fluid in body, the excess fluid in body. Okay, so we don't want to restrict fluid. What can happen if we are restricting fluid? What can happen? Dehydration, yes. Electrolyte imbalance, definitely. Okay, definitely. Okay, let's move to question number 12. Hello pyridol. Yeah, definitely hypovolemia too. Hello pyridol, what kind of medication is hello pyridol, guys? What kind of medication is that? Yes, queen, I can go back, definitely. Here you go. Is it done? Antipsychotic, yes. Is it typical or atypical? Is it typical or atypical? Atypical medication. It is first generation, actually. It is typical medication. Yes, Ashley, it is typical. Yeah, yeah. Okay, so it is just blocking the D2 receptor in the brain. Okay, now it is typical medication blocking most of the D2 receptor in the brain, mesolimbic pathway. Can we expect extrapyramidal symptoms? Can we expect extrapyramidal symptoms, guys? Yes. Okay. Yeah. Yeah. Extrapyramidal symptoms. Yes. Alrighty. What can we have neuroleptic malignant syndrome? Yes. The reason behind this one also because it D2 receptors are everywhere. D2 receptors are everywhere, guys. Okay, so when we have haloperidol, it block the D2 receptors. Okay, and that release a lot of calcium in body. Okay, and that cause what is the symptom of neuroleptic malignant syndrome? When we first start the med or increase dose, yeah. What is the symptoms of neuroleptic malignant syndrome? Anyone? Muscle stiffness? Yes. Muscle rigidity is the main one, and hyperthermia, because what's happening now, we have too much calcium. It this medication release lot of calcium from the stores, internal stores, so that's why there is too much calcium. And what calcium do? Calcium stabilize the membranes. Okay, so now it's too much stabilized, and it is causing muscle stiffness, muscle rigidity, hyperthermia. Okay, let's do next one. Agranulocytosis. Do we need to worry about agranulocytosis? Yes or no? Which medication? Okay, which class of medication cause agranulocytosis? Is it typical or atypical? First generation or second generation, guys? So we don't have agranulocytosis in haloperidol. Okay, we see it in second generation medications. We see it in second generation medication, not first one. Okay, tardive dyskinesia. Yes, so D is yes, D is big yes, because we are blocking too much D2 receptors in the brain, and it trying to compensate body, and now there is too much involuntary movements. Okay, can we see hypertensive crisis? Are we giving this medication for hypertension? No. Yeah, so we don't need to worry about hypertensive crisis in this medication, because usually we see hypertensive crisis in medicine that we give for hypertension. Okay, question number 13. We only gonna do 20 question in this session, guys, so we only have 8 question left. So make sure you stay with us, and then later on we will come live again. Okay, the nurse is teaching about nitroglycerin sublingual tablets. Which statement should be included? Select all that apply. What kind of medication is nitroglycerin? Yes, Pradeep, I will tell the timing at the last. Vasodilator. Yes, it is very potent vasodilator. Okay, do we need statement should be included? Yeah, so do we need to tell patient about placing this under the tongue until dissolved? Yes, because it will help to absorb directly. It will help to absorb directly. Can they take 3 doses in 15 minutes if needed? Yes, one dose every 5 minutes. Yes, one dose every 5 minutes. Okay, and maximum 3 doses are recommended only. Okay, what will happen if patient still have pain after 3 doses? What we need to do? Can we give fourth one? Go to ER. Yes, definitely. Notify the doctor, go to ER. No fourth. Okay, that's good one. Store in a dark, tightly closed container. Is C correct? Yes. What will happen if we are storing, if we are letting in under the sun? We don't want any sunshine over it. The potency will reduce. Okay, so we need the effectiveness will reduce. So we need to store it in dark, tightly closed container. Yeah. Yes, Queen, definitely. Swallow the tablet with water for rapid relief. Is it recommended to do that? No, we need it sublingual. Okay, we need it sublingual. So we can't do that. Okay. Do we need to call 111 or 911 if chest pain persists after one dose? Is E yes? Yes. Okay. Regardless whether we still have two more doses. No, Pradeep, no. For safety concerns, safety is always essential. You don't want to wait for 3 doses first. Okay. Okay. So once you given one dose, yeah, once you given one dose, and if patient is still having the pain, for patient safety first you guys need to call 911 or 111. Okay, whether they are sending the help or not, it's depend upon them. Okay, but at least they will give you the indication what to do, and just follow the protocol. Whatever they will recommended. Okay, they definitely gonna recommend to go to the 3 dose. But what, yeah, okay, it's we can give three, we can give three, but what happen if it doesn't resolve after three? What happen if pain is resolved in first dose? What it is indicating, guys? If pain relieve with first dose, what it is indicating? Angina, yes, it is angina. Okay, and what if we are having pain even after 3 doses? What's it indicating? MI, yes. So that's the reason. If it is angina pain, if it is angina pain, then it's definitely gonna, yeah, yeah, it's definitely gonna relieve with one dose. You will see bit of the effect. Okay, but if it is MI, it's not gonna relieve after first dose. That's the usual concern. That's why we call 911 or 111 after first dose if it is not relieving, because it's always too good to go with safety. And our, even in the real world, real practice, and even in the exam, our first priority is patient safety. Okay, so we don't want to lose that one. Yeah, so we can call 911 or 111. Yeah, and if we are just waiting for 15 minutes, what's gonna happen if we are waiting for 15 minutes to see whether it's effective or not? We are losing time. Yes, and especially in MI or heart attack, it time is critical. Okay, time is very critical. Yeah, so you don't want to lose that time. Alrighty. Question number 14. Which findings indicate aminoglycoside toxicity? Select all that apply. We done gentamicin yesterday. We done this medication yesterday. So please let me know. And I really want bit of rational along with your answers. Okay. Can patient have tinnitus? Yes, autotoxicity. This is what we need in the answers. Okay. Please, if you know, please put that word also. Okay, most of the aminoglycosides have autotoxicity. Yeah, fluid accumulation in the inner ear, and that's why you get tinnitus. Okay, proteinuria. Proteinuria. No, guys, please keep double tapping the screen if you are not commenting. Just for nephrotoxicity? Yes, definitely. Okay, because it filtered by glomerulus. Okay, yeah, and it does reabsorb in proximal tubule. So we have higher chances of proteinuria due to nephrotoxicity. Okay, it can when it keep collecting into the proximal neural renal tubules, proximal renal tubule, then it cause injury, and when we do have the injury, more protein we lose more protein through urine. Okay, elevated BUN and creatinine. What's gonna happen with nitrogen and creatinine? Is C? Yes. So same rationale about C also, because gentamicin is very toxic. Yes, gentamicin is very toxic. It is causing kidney damage. Yes, kidney problem. So we're gonna see nitrogen, blood urea nitrogen, and creatinine. Okay, so that's definitely muscle rigidity and fever. We just done that one before. What are the signs? What are the indication of muscle rigidity and fever? What's happening here? Redman syndrome? No. Redman syndrome, we have angioedema of upper torso, face, and neck. Rhabdo? No. Rhabdo, you have pain in the thigh or pain in the muscle. And then, yes, just a neuroleptic malignant syndrome. That's the one. Okay. These are the classical sign of NMS. Yes. Okay, so do we see NMS in glycosides? Which medications we see NMS? Yes, so this is wrong. Which medication, which class of drug we can see these one? What class of drug we just discussed? Yes, future RN, definitely antipsychotic. Antipsychotic medications can cause NMS. Okay, so not aminoglycosides. That's the typical side effect of antipsychotic. Okay, good one. Nystagmus. What is nystagmus? We just done that eye issue. Yes, involuntary eye movement, rapid eye movement. Yes. Can we see that one into gentamicin? Yes, I move weirdly, definitely. Okay, we're gonna see actually just no and me, just definitely. We're gonna see nystagmus. Why? Because we are having ototoxicity, and we have ototoxicity. Involuntary eye movement is sign of vestibular in ototoxicity. Okay, so when we having tinnitus, you can also have nystagmus. They are very closely related to each other. Okay, so you will see that one. Yes, please do bit of research, just put on your copy and just see like why it happened. Okay, because vestibular ototoxicity can cause nystagmus also. Okay, question number 15. We have 6 questions left and we have 6 people left to subscribe. So make sure you subscribe YouTube also, cause next live will be on YouTube soon, maybe after a couple of hours. Okay, a nurse is caring for a patient receiving heparin infusion. Which intervention are correct? Monitor APTT level. Do we need to watch for thromboblast in time? Yes. ABCD? Yes. Okay, so we're gonna watch this one just to make sure we have effective medication balance in body. Okay, have protamine sulfate available? Is B yes? That's the antidote. Yeah, it's always good to have antidote with us. Very important. Administer IM injection for faster absorption. Can we do it IM? No, yeah. What's gonna happen if we are giving it IM? Ineffective? Bleed. Yes, John, definitely. It's gonna bleed. You will have higher bleeding chances and hematoma. So we don't wanna give it to IM because of that. Do we need to watch for bleeding gum and bruising? D yes, yes, always, because then we need to adjust the dose. That means we are going toward toxicity. Can we use small gauge needle for venipuncture? Is E correct? Okay, so yes, future and definitely we can use small gauge needle because that will create less injury to veins. Okay, and there is less chances of bleeding now and hematoma. Small needles always yes with heparin. Okay, don't use it in like other one. Yeah, 16. So we got metoprolol now. A patient is prescribed metoprolol. Which teaching point are correct? Select all that apply. Check heart rate before taking. What kind of medications are metoprolol? Beta blockers? Yes. So definitely it's gonna affect the heart rate. So we need to check the heart rate. What we need before giving beta blockers? How much heart rate we need? What should be the pulse? 60. Yes, definitely we need at least 60. You can hold it if it is less than 60. Okay. B, do not stop abruptly. What will happen if we are stopping it abruptly? Hypertensive crisis, yes. Rebound, definitely. And this is what we are seeing in lot of answers options before. So likewise I was telling, like, you will only see hypertensive crisis in medication that you give for hypertension. So definitely you will see hypertensive crisis, so never stop it abruptly. Okay, do we need to report wheezing or bronchospasm? Yes. Yeah. Yeah, because what's gonna happen, it also affect the, because what is metaprolol? Is it selective or non-selective? Yeah, we never give it in asthma, but that is not the question. Yeah. Yeah, it is selective. Yeah, it is selective, but what it can do when we give it in higher dose, especially, it can block beta 2 receptors also. Okay, basically it work on beta 1, very selective, but when we are having higher dose of metoprolol, sometime you need to give it. It can affect beta 2 receptor in bronchioles, and that's why you will see wheezing and bronchospasm. So we definitely need to report it. That is the another reason, if patient is already having asthma, we don't yeah, which make it worse. Definitely, if patient is having asthma, then we don't prescribe metoprolol, or we need to carefully watch it. Okay. Yeah, yeah, ccp can be, yeah, ccp can be good. May mask hypoglycemia symptoms, can it? Yeah, because what it is beta blocker. It is beta blocker, and what beta 2 receptors, we do have beta 2 receptors, that also mediate the adrenergic response to hypoglycemia. Okay, so when we have that one, it can mask hypoglycemia. Okay, it can mask hypoglycemia symptom, especially even if it is causing the hypotension. If it's slowing down the heart rate, then definitely we're gonna have less perfusion, and that will also do that same. Okay, take on an empty stomach. E, does it have any relationship to food? Okay, so we don't want to take it on empty stomach. Actually, we need to take it with meal. Just per day, we need to take it with meal. Okay, because it is known to increase absorption. Okay, with meal, we see increase absorptions of medication. We have four more questions left, guys, and then later this evening we will do live on YouTube also. So please make sure you search Nursingy, and you will see the same logo on our channel. Okay, make sure you do that, please. Okay, a nurse provide discharge teaching for a patient starting levothyroxine, which are important to emphasize. Select all that apply. Okay, what time we usually take levothyroxine? Morning, empty stomach, definitely. Okay, before breakfast. So that's correct. That's definitely correct. Can we expect improvement in symptoms within days? How long it take to act? How long is gonna take? Yes, 4 to 6 week. Yeah, yeah. It can be different, but basically four to 6 weeks. Okay. Yeah. So we can't expect improvement in symptoms within days. Report chest pain or palpitations. What can happen over there? Yes, we need to, because we are giving thyroid hormone to patient right now, and sometime increased dose can cause hyperthyroidism. That's why we can have chest pain and palpitation. Okay, yeah, because it is putting strain on cardiovascular system. Do not switch brand without consulting provider. What will happen to patient if they are switching the brand? Because every brand have different bioavailability. Okay, so switching, yeah, adverse effect can occur. We don't know which brand is gonna work better or not, so it's always good to stick to one brand to see and maintain the therapeutic level. Okay, and is thyroxine lifelong therapy? Yes. So E is yes, actually, because hypothyroidism is a chronic condition and patient might need to take it for life. Yeah. Yep. So definitely 17 is correct answer. Okay, three more question, guys, and then we are gonna be done with this. Which symptoms are associated with serotonin syndrome? Okay, definitely. What is serotonin syndrome, guys? We discussed that at starting of this session. Excessive use of SSRI, yes. Everything goes high, yes. Too much serotonin, definitely. Everything goes high, and you can remember it by harmful. Okay, HARMFUL. Okay, hyperthermia, agitation, muscle rigidity. Okay, myoclonus, that's jerk, muscles jerk. Okay, F, fast heart rate. U, unconsciousness. Late side is fatal. So set it 20. Syndrome is wearing movement, headache, sweating, take too much sodium, body CNS. Yes, that's the one. Okay. So hyperreflexia. Now we already discussed all the symptom. Shall we see hyperreflexia? Yes. Okay. Everything goes high. Everything goes high. Fever and diaphoresis. Are we gonna see that one? Yes, definitely. Hypothermia and diaphoresis, high sweating. Severe hypertension. Yes, again, severe hypertension gonna be there. Okay, there will be severe hypertension. Confusion and agitation. Yes, yes. Too much thing going on in brain right now. Do we see constipation and bradycardia? No, because this is not going up. This is going down. Okay, you might can see the diarrhea, but you can't see constipation. You will see tachycardia, you will not see bradycardia. Okay, because this is going down, so you need diarrhea here, you need tachycardia here. Okay, thank you, someone went over there again. We are 95 now. Next live will be on YouTube, guys. I will give you guys time soon. So the nurse is reviewing meds for a patient on cyclosporine post-transplant, which finding need follow-up. What kind of medication is cyclosporine? Immunosuppressant? Yes. Okay. Yeah. Calcium one? Yes, definitely that one. Okay. Um, Select all that apply. Gingival hyperplasia. Can we see that one? Thank you, Sidhu. Yes. So we're gonna see gingival hyperplasia over there. Okay, same thing, because it is very common side effect of cyclosporine. Okay. Yeah. Tremors, especially in the higher dose, guys. Can we see tremors? And why we see tremors? Yes, we see tremor. Anybody, why we see tremors? No. Okay, that's it's okay. It's okay. We do have nephrotoxicity. We do have mild hyperkalemia. Okay, and it cause neurotoxicity also. Okay, that's why you see tremors. Yeah, creatinine 2.2 mg per dl. We talk about that. What is normal level of creatinine in body? We discussed that at starting. It is common finding. It is common finding. It is very common. 0.6 to 1.2. Yes. So 2.2. What it is indicating? It is 0.6 to 1.2 Pradeep. What it is indicating? Nephrotoxicity. Yes, we are having nephrotoxicity. So definitely it is very severe. It is, we need to see. Okay. Blood pressure 160/90. Yes, because it affect on kidney, it affect on vasoconstriction, so we need to hypertension. Yes, and mild hyperkalemia. Yes. Okay, guys, we need to all answer are correct in this one, because this also affect the enzyme that produce aldosterone. So that's why you need to worry about blood pressure. That's why you need to worry about hyperkalemia, because aldosterone, what aldosterone do? Aldosterone help with the excretion of sodium and water and potassium. Now we don't have, just can affect heart as well. Okay, we don't have that much, and everything is staying inside the body. Okay, so that's why potassium retention is there. Okay, last question, and then we're gonna finish for this session, and then we will be live on YouTube after few hours. I will give you guys time. Definitely I will give you guys time. The nurse is preparing to give clopidogrel. Which patient teaching points are correct? Report black Terry stool. Do we need to worry about that? Yes. What kind of medication is clopidogrel? What kind of medication this is? Signs of bleeding? Yes. Antiplatelet? Yes. Okay. Avoid aspirin and NSAIDs. Do we need to avoid aspirin and NSAIDs? Definitely, because aspirin is antiplatelet. NSAIDs also inhibit the COX-1, COX-2, okay, prostaglandin, and that can cause the bleeding. So that's why we need to avoid aspirin and NSAIDs. Alrighty. Next one. Routine blood test monitoring required. Do we need to do that with clopidogrel? Okay, so guys, we don't need a routine blood test for clopidogrel. Okay, not routine. Yeah, which medication need routine test? Which medication need routine test? Warfarin and warfarin and heparin. Yes, definitely. Okay, so we don't need one for this one. Stop medication 5 to 7 days before surgery. Is it correct? Yes. Okay. Yeah. So we need to stop it at least 5 to 7 days before, because what it inhibit the platelets. Okay, it inhibit the platelets, and platelets gonna take 7 to 10 days to come back into actions. Okay, if we are not stopping it, there is higher chances of bleeding. There are higher chances of bleeding. Okay, take with food to minimize GI upset. Can we do that? Or can we take it with or without food? That can be the better question. Okay, so clopidogrel doesn't irritate. Okay, there is no indication. It can be with or without. Okay, yeah, yes. Okay, so we don't need to worry about food here. And this is our set of 20 questions that we done today. It take us at least maybe a couple of hours, 2.5 hours. Okay, so we were live for 2.5 hours. Have been good pharma review. We have 50 question in this document. Maybe in next one we will try to do 30 questions. Okay, I'm gonna post one by one medication, including mode of action, including side effects, how side effect happen, including what we need to watch as a nurse on our YouTube channel. Because once I'm doing this one,